welcome everybody. Welcome to Clear Week 2023, where we'll be showcasing the work of frontline staff who've been delivering innovation projects within their clinical services to drive change. And welcome to day 4. This is the second session of today, entitled Expansion of a Dedicated High Intensity User Service in East Warrington to Provide More Proactive Care. This session will explore the Clear High Intensity User Project, and we'll look at the positive impact of a dedicated high intensity user service is having in East Warrington, and how aspirations to expand the service across the system to improve the quality and efficiency of care for patients in this cohort. Please note that the webinar will be recorded so we can share the learning with others who aren't able to attend at this time. And please don't forget to follow us on Twitter to share your thoughts on the session using #ClearWeek, and our handle is @ClearForCare. So our speakers today are Rob Dandy, High Intensity User Lead at Warrington Borough Council, working in partnership with the NHS, Jackie McLaughlin, High Intensity User Lead at Warrington Borough Council, working in partnership with the NHS, Tricia Kavanagh-Wilkinson, Programme Manager at Cheshire and Merseyside Integrated Care Board, covering Warrington, and Claire Brewster, Clear Anticipatory Care Clinical Lead and former Clear Associate and Fertility Specialty Nurse. I think that's it from me. So I hope you enjoy the session, and I'm going to hand over to Claire.
Thank you. Hello, everybody. Thanks for joining us today. We're going to tell you our story really around our high intensity user work, and that came off the back of our anticipatory care work that we did last year with 5 PCNs in England. And just go on to the next slide. I'll just give you a little bit of context around our project scope and what we did. So we were asked by NHS England to look at high intensity users of primary care, and we used the NHS England definition of patients who had 5 or more visits in the last 12 months. What we did was we looked at all the patients in the PCN who'd had 5 or more recodes for A&E attendances, and we looked at data from August 2020 to July 2021, so we had a full 12 months data. We were able to define the HIU cohort. We compared this cohort with all patients who attended for care within the PCN, so we were able to compare their activity with all registered patients within the PCN and GP practices. And we found the initial analysis, we found that they had a lot more activity as expected, but we also looked at demographic details and comorbidities of these patients, which we'll talk about shortly. Just move on to the next slide. Thank you. And this is just really a little bit of context around why we're looking at them really and why it's important. And the British Red Cross report, Nowhere Else to Turn, in November 2021, is a real good read around high intensity users and what, you know, the needs and kind of what care needs to be in place for these patients. It's also part of the NHS long-term plan, and we've got a lot of other papers, especially the operating planning guidance for 2022-23, which looks at urgent and emergency care and how we can support patients who've got our high intensity user and complex needs. And really, these are just some statistics really around high intensity users. And the people who frequently attend A&E make up less than 1% of England's population, but they account for 16% of ambulance journeys and 26% of hospital admissions. They cost the NHS £2.5 billion per year. They're closely associated with deprivation and inequalities, and the most common age group of these patients are between 20 and 29, and those over 70 years old. The people who frequently attend A&E have a wide range of physical and mental health conditions. They are complex patients and they can be quite hard to manage. High intensity user services already exist in many areas, and we found that especially with East Warrington, one of the sites that we work with, but they are very secondary care focused, and they take a lot of their referrals straight from ED rather than the primary care and the GP surgeries, and there isn't that robust service nationally in place at the moment. So we kind of looked at patients that we could that we saw within our PCNs, and that, you know, what we could do differently and what we could do to support the PCNs in developing a new model of care, to try and support these patients earlier in their journey before they reach crisis point. We just move on to the next slide. So the recent anticipatory care project, we had 6 sites, and these are highlighted on the map there. So we had 3 up in the Manchester, Cheshire region, and then we had Regis, Camden and East Lindsey, which was in Norfolk, Lincoln. And then we looked at analysis of data, as I've said, from August 20 to July 2021, and it showed that 0.01 to 0.4% of PCN registered patients were defined as high intensity users, and it accounted for between 65 and 289 of registered patients within those PCNs. So it was a really small number of patients. However, as the national data highlights, the GP appointments for these cohorts of patients ranged from 896 to over 5,000, and that equated to 0.8 to 1.4% of total GP appointments. So again, not a lot of GP appointments, but a lot more than what their actual standing was in the register. The HIUs accounted for 15.4% of ED attendances and up to 20% of emergency admissions for all registered patients within those PCNs. So their activity was really high. Just move on to the next slide, Emma. This is a summary of our findings over the 5 PCNs that we looked at in more detail. And we can see on the top line there in the box that we've got the 5 PCNs across the top in blue, and the cohort of patients that were in those PCNs. So again, we've said from 82 to 289. We then looked at the GP appointments, the median GP appointments per HIU patient, and then we looked at the A&E attendances, emergency admissions, and what was really interesting to me was the distinct medications as well. So they had a real higher number of distinct medications per patient than the normal average patient within that PCN. We did a quick kind of cost evaluation of these groups of patients, and as you can see, Regis's cost was over £1 million, and varying, but all nearly equated to, you know, £500,000 for this small group of patients. We'll just move on to the next slide. What we kind of found out about the HIU cohort, and this was across all PCNs that we looked at, was that at the age, we looked at the age range of patients, and in the orange on the left is the orange patients are the high intensity users, and the blues are the full population of the PCN, and we saw 3 distinct age ranges. So we saw the young babies and the young children below 4 years old. We then saw the working well group of patients, so that was between 20 and 40 years, and then we saw a bunch that was high in the elderly population, and that could account for the frail population. We also then looked at deprivation scores, and we found that the patients in the lower deprivation scores had a higher number of high intensity users within that group. This slide is from HIUs, one of our PCNs that we used, but it's representative of all the PCNs that we used within our work. Let's move on to the next slide. So we then kind of thought, well, what could we do? What areas of action could we help and recommend, really, from the care that we'd seen and the data that we'd seen? We did some limited clinical engagement, and we did find that there was very little services based in PCNs and community practices around high intensity users. So we reached out to the sites, and we got in touch with East Warrington and Rob and Tricia, and we shared the data with them, and we kind of understood what services were already in place, very much secondary care, and they're going to talk to us about their service already. But it was kind of working together, really, and how we could put in place appropriate non-clinical specialist support, improving access to community-based support, and how we could address health inequalities, So we then went on to look at a new model of care and how we could recommend a new model of care for PCNs. So we can just move on to the next slide, Emma. The recommendation for the model for the high intensity user service is quite complex, like the patients really. We had to kind of ensure that we covered all the needs that the patients will need, and because the age range was quite wide as well, we had to kind of make sure that the care was very broad. What we did know after talking to a lot of other people in the service was that these patients were using a lot of GP appointments and a lot of medical time, but actually a lot of their need wasn't medical, and they needed a lot of help with practical, psychological, and just general kind of physical care and functional care. So we looked at how we could implement and recommend a model that looked at care coordination, clinical management, and that was around proactive management of long-term health conditions and how we could look at regular structured medication reviews. So as I said earlier, these patients were on an awful lot of medication. How we could support them functionally, so proactive enablement through dedicated therapy support, and that might be referrals out to mental health support workers or any other addiction type support workers to help with their function and daily living. We also looked at health and wellbeing psychological support, so health coaching, psychological support, helping them to stay as healthy as possible, both in body and mind. Practical support, so looking at personalised advice and support with benefits, budgeting and housing, and then looking at service management. And that's really important when you're looking at a new model of care, of how we can use administrative support and data to ensure that the right people are benefiting from the service, but how we can also monitor outcomes and identify this group of patients as well, because that's quite tricky, of identifying the cohort of patients that need some care. What we then went on to look at was the a workforce tool that we use. If you can just move on to the next slide, Emma, that'd be great. And we called this the HIUs matrix, and it was developed by one of our teams who were working in HIUs, but it was kind of adopted. It's been adopted by all the teams that were working. So it's just really a tool that we can kind of look at a cohort of patients. And as you can see for this one, our cohort is high intensity users. And again, if you look at the table on the top, we've got what cohort of patients are we looking at. So we're looking at high intensity user patients and what numbers have we got. So within the HIUs PCN, for example, we had 228 patients that we identified within that 12 months that were high intensity users of the service. And that was service within the PCN. So what we then kind of looked with the models that we'd looked and the research that we'd done was what care did they need, and how we could model that and help with the drivers, the national drivers and local drivers. So looking at the QOF, and we're looking at the national unplanned activity and how we could kind of measure and look at the impact of these services. So we looked very much along the model that I showed earlier around care coordination, how we could clinically manage these patients with long-term conditions, how we could do the structured medication review, etc., etc. And within that, then we looked at, well, how often do these patients need to be seen? I know Rob and Jackie will talk about their model shortly, but this was looking at how we could model a care for these patients. So again, for like care coordination, we thought about 60 minutes twice a week for the first 12 weeks. And that would be their named care worker that would have a high impact initial work with them for the first 12 weeks, and then that would be reduced. And weaving along with that would be the medication reviews, referring them for functional and health coaching and psychological support. So that's how we modelled the care. And just move on to the next slide. I'm just now going to talk about East Warrington and what we did there. So I'm just going to talk more specifically really about East Warrington, and then we'll introduce Rob and Jackie. So the challenge in East Warrington was that they had a higher than average percentage of high intensity users, and they were taking a disproportionate amount of GP time. In East Warrington PCN, we identified that there were 144 patients, and they accounted for 14% of ED attendances and 20% of hospital admissions. They'd got much higher levels of comorbidities and many more medications. They were on average of 29 compared to 7 of the general population at the PCM. And also they had an average of 7 GP appointments a year compared to 3 for the general population. So we looked at how we could devise a new model of care, and we actually costed that out and looked at how many hours per year that these patients would need from the different roles that we offered within this multidisciplinary model of care. And we costed that up, and we worked with the teams around the funding through the HIUs roles and how we could look at social prescribers and mental health practitioners and coaches to improve their quality of life. This model of care is working with the current HIU service that's already in place in Warrington, and it would have a dedicated team that would supply a broad range of services. We hoped that this model of care would lead to a significant reduction in GP appointments, ED attendances and hospital admissions. And for East Warrington, that actual unplanned care cost £520,000. And if we reduced this activity by 25% for GP appointments and 40% in unplanned secondary care, we would probably save about £122,000. So the figures were really startling, really, about how we could just have a small interventions and it could have quite big results. So I'm going to hand over now to Rob and Jackie, and they're going to tell you a little bit about their service that they've got in Warrington, and then we'll have any questions afterwards, if that's okay.
Move on to the next slide, please.
Okay, is there any chance now maybe I could share my screen just with the updated presentation?
Yes, that's fine.
Yeah. Can you all see that?
Yeah, we can.
Wonderful. If at any stage that you can't, just give me a shout. So firstly, welcome everybody, and thanks for having Rob and myself here.
You're on mute.
There we go. So a high intensity user is defined as a patient with 5 or more visits to A&E within a 3-month period. The Northwest, so a little bit of background, I suppose, for those that may not know, the Northwest of England experienced a 28% increase in the number of high intensity users in 21 compared to in 2019, which was 8,415. With those visiting A&E 10 or more times, counting for 4.5% of all A&E attendances. Now, that is a serious number. Obviously, there was 3,051,459 A&E attendances in the Northwest in 2021. So that is a massive amount. So again, HIU programme, it supports people who frequently attend A&E and aims to reduce admissions to the emergency department and the burden on emergency services and other NHS resources. HIU clients regularly call an ambulance or attend A&E when they feel they have nowhere else to go. These are often vulnerable people who may be experiencing a combination of physical health conditions, substance misuse, depression, anxiety, abuse, financial problems, or homelessness. Very often, A&E is not the most appropriate and sustainable care option for these clients. The HIU programme aims to connect with frequent users of NHS resources and adopts a supportive, non-medical and a social coaching approach to patient care instead. Now, we find that this here is really important. Obviously, when the likes of our clients, they go to A&E, you've got all the clinicians there that are able to obviously give medication as and when needed. But as we all know, the the clinicians, they don't have the time or the resources to find out what is the underlying issues that maybe the patients are turning up to A&E for. So that's where we jump in as well and really get to the root cause of it. So the programme strives to connect patients with community-based services and organisations to better suit their needs. Now, some of the patients, we call them clients, they may be suffering, they may need help with benefit support, housing, maybe substance, alcohol misuse. So we would then liaise with the various community services. We also, some of our clients, we introduce them to volunteering. It might be mindfulness courses. They may be struggling with stress, anxiety, might be controlling behavior, might be anger. So again, introduce them to various things within the community. It might be CBT based approach. For some, it might be social isolation. So we take them out and about, coffee mornings, lunches. It might be a befriending service, companionship services. Others, it might be support with employment, transport that may be needed as well. So some of the clients that really can't get to where they need to be because financially they don't have that. So that again is where we jump in and help them out. And then we take a more collaborative approach to care and support afforded to high intensity users of A&E, and it's essential if we are to improve health outcomes and service user experience while reducing avoidable interactions with secondary care and all care systems. So how it works. So for Rob and myself, the patients are identified. So a list of most regular attendees at A&E identified by analysis of A&E data systems. So that for us would be our lead clinician at Warrington ED department. And those are the additional high risk clients may be selected. So it's minimum 5 attendances per quarter. So that's how the clients are put to us. So the contact then, so once Rob and myself are given the clients, we then we contact them via phone, introduce ourselves, and then we call around for a home visit so that they can actually put a face to the name. And that way we can build genuine human connection with them. We focus on the client's perception of the issue and demedicalize their needs to uncover the real issues. So why are they turning up to A&E? Maybe 4 or 5 times in a week for some of the clients, believe it or not. So it's really finding out, digging deep. Then to engage, so supported referrals and signposting, plus creative and motivational coaching work completed with the client to engage client with the community services, community projects, friends and our family. So what I've just spoke about previously. Then to de-escalate, so de-escalation of the service offered by the project. So phone contact with the HIU lead to provide immediate access to listening support related to the social, emotional, financial or family issues. Exit strategy. So once the client has engaged with suitable support services or community contacts and they feel a fresh sense of purpose and connection, the service will be tactfully withdrawn at an appropriate pace. Obviously, Rob and myself will work with the client, we say for up to 12 weeks. Now, obviously, we work with very high complex clients. I know some of the other HIU leads in the UK, you would take 15 maybe clients up to 20 at a time, and they may be a selection of high, medium and low complex clients. Now, since Rob and I have been in the role since 2019, all of our clients have been high complex. So for some of those, 12 weeks have not been enough for them. So it might have been that they were coming to the 12-week period and they were going fantastically well, but then they received maybe some bad news that set them back. Now, obviously at that point, we were not going to step them down, so they would just follow on to the next cohort of clients. And then when I suppose we deem fit that, they were stable and able to have a positive outlook at that point, then the exit strategy would be put into place. Now, any relapse at all, the clients would always have our phone number. And if because the relationship that we would have built up with the clients, they would feel as though they could ring us at any point, any crisis point, give us a call, and then we would jump back in and, you know, aid that support for them. So what I spoke about before about community-based services, now some of the relationships that Rob and I have built up within Warrington, I think if you can see on your screen, that's a small amount of them, but we feel as though having the relationships with each and every one of these organizations, it's a great tool to have for the clients that we work with, that we can just jump in and we've got one representative maybe in each one of these. So it might be within adult safeguarding team. Now we work closely with those, and obviously Core 24 for adult mental health. So we have those sort of at our fingertips. And then finally, if anybody has any questions, feel free. And thanks for having us today.
Thank you. We are expecting Tricia. I don't know if she's arrived yet, but is she here yet? No, I don't think she is. So Tricia is our so she's our programme manager within Cheshire and Merseyside Integrated Care Board, and we've been working with Tricia and Rob and Jackie around how we can kind of share the work. So what we've found is that there's this gap, and Jackie and Rob, you'll probably agree, is that you take a lot of your patients from secondary care and A&E, but we've got this group of patients that are, you know, sat in this PCN that perhaps aren't known to you as well. So it was how we can kind of combine and expand the services. So the work in East Warrington at the moment now, when they saw the data that we showed them from CLEAR, they were amazed at how many patients were in the PCN that were classed as high intensity users. Jackie and Rob, your caseload, what roughly is your caseload at any one time of patients?
It was 15 per quarter, but we've upped it to 20.
Right, okay.
Now again, we've been given the list from the hospital now, and from those, for the first time in I think the 3 years, that we have been given a selection of clients. So whereas before it was all high complex clients, we now have a mixture of medium and low. Well, I say low, they're not that low of complexity, and yeah, it's going well at present.
Yeah, but it's just kind of small, isn't it? You know, still that 20 patients for the whole of Warrington, compared to just that 144 in one PCN.
Yeah, what we have noticed with the latest data that we've received is that there is a number of patients from that PCN that you're talking about, the East, and the vast majority of them are over 70. Right. And that's something that we've been able to identify over the last, let's say, 6 weeks since we've had the list.
Yeah, that's interesting, isn't it? And I know we've got a question, so I'll go over to Eve, who's got a question for us.
Hi guys, I hope you can hear me. I'm just walking the dog and listening with interest to your talk. It was really great, thank you. I was just wondering, because you talked about the peaks. I think it's partly been answered just now in terms of the over 70s, but there's that peak in the kind of adult, I think it's around 30-40 of activity, and then the peak in older age. Do you feel that this model works for both of those cohorts, or are there any differences in engagement between those two different cohorts with this approach?
I think it's sometimes harder to engage the over 70s. Now, the reason for that is over the last, 2.5, 3 years with COVID and things like that, they're a little bit more anxious about being able to go out and mix in community groups and the lunch clubs and things like that. And a lot of the ones that we see that are over 70 have frailty issues. So that's a big cause. So obviously that some of the things that Jackie and I do, we'll refer to the frailty team, we'll look at social care, we'll look at sensory assessment team and things like that. So they're the hardest ones to engage with. Now, from the research that we've done and the reports that Jackie and I have done over the last 6-8 weeks, we're doing the procurement. Our biggest cohort is the 35 to 46. That's our biggest cohort.
Yeah.
And it's females
really
predominantly.
Yeah, I in my head I thought it would be the other way around. I'm not sure why, but thank you.
I think for that other answer, if you look to the stats down the country, so the likes of Devon and Cornwall, then yes, it isn't as high. The age bracket is not as high. For whatever reason, I don't know.
I guess deprivation will have some factor there, won't it? And I think the more urban areas compared to the rural areas, we will see a difference within those cohorts. And I think we did see that slightly with Regis, actually, down south, that we saw slightly different ages within that population of high intensity user patients.
And that's the thing with Warrington as well. We're very unique in the sense that our deprivation is in, if you think of a donut, ours is in the centre. Now the outskirts of Warrington is very affluent, but over the last several years, I know that there was a new report released not too long ago, said that the likes of Thelwall and Grappenhall, that have always been notoriously a very affluent area, is now falling into that level of deprivation.
Yeah. And how are you finding your communication with GPs? Trying to join the dots, I guess, really. So you've got these patients on your caseload. How are you finding that interaction with primary care?
It would vary on the GP practice. So as we touched on before we started, unfortunately, the PCNs in Warrington, they've not really got on board with the HIU thing. Now, as I said earlier, I don't know if that's because Jackie and I have never been present at these meetings and things, and they don't quite understand it, and it's not being relayed in the way that Jackie and I would relay it. But there is one or two practice managers that are very, very open to it. And what we find is that they are keen on our support, but it's just trying to get that as a wider context, basically.
Yeah. Okay. Thank you.
We bring Caroline Tomsett in, who I think has a question.
I just want to ask you both, considering the pressure that the NHS is under at the moment, what do you think the potential is for expanding services like yours more widely across England?
Massive. Now, obviously, I don't know if you were on when we were chatting at the start, but from Rob and I started in our roles in 2019, there was, I think, did I say 60 odd HIU leads in the country? We're now up to 125 to 130. It is expanding without a shadow of a doubt. America is looking to buy the service. It's currently in Western Australia. Now, there is other people, other boroughs within the UK that are looking to, I think, copy this model as well, the NHS model. So the expansion is going to be massive for it. And not only that, but I think primary care as well. There's a gap in the market, shall we say.
And I think that's the thing with Warrington as well. We're trying to be, we're looking at different areas of where we could expand the service. Now, obviously, we're going through that procurement element of, the interesting thing to see if we're going to get the service long term. But if we were successful in that, we would be looking at expanding it to the PCNs. And we already have great links within social care, and we're well aware that most of these HIU cohort are accessing them services as well, like Care Call, for example. And the pressures on those services are just as great as ED. The only thing is, with ED, you can actually put a monetary value on it. With these other services, you can't. But it's still time what could be best spent supporting individuals that actually need the support, rather than, they're looking for a befriender, or they're looking for additional information on whatever it may be.
I don't know when you covered it earlier, but what's been the sort of peaks and troughs of the service. So after COVID, have you seen a great rise, or was there a bigger rise during the COVID period
It's all been the same.
in demand?
Yeah, the demand's
Demand.
not. It's just the same. I think from the information that we've got, I think the busiest times for the frequent attenders is normally the winter months. So October to March, that's the biggest time.
Yeah.
And that also coincides with obviously your flus and your things where the ED pressures are far greater than any other time.
Makes sense. Thank you.
We've had an interesting comment from Eve. I don't know, Eve, if you're able to ask this, or I can.
Sorry, my phone battery's dying, so I think it's turned the volume down, so I'm struggling to hear a bit. But yeah, no, I just put a comment on there because I just there's this company that has been formed in the States that, off the back of insurance, actually, I think, they were initially set up for veterans, because veterans in America have access to a lot of services and a lot of complex health, physical and mental health needs. And there were these two veterans working with these veterans to try and connect them with the services that they could access to help them manage their problems. And they've expanded this to healthcare, so that if a patient goes into hospital, they have this health assessment essentially that looks for social determinants of health, really, and it gets put into this software, and it pumps out options for them, and many of the options are the options that you described in the model of care. So it will give them access to food banks, it will give them access to things like homeless shelters, it'll tell you where there's availability for things like rehab services, and I just thought it was quite an interesting bit of software that might be worth considering for this type of work. So it wasn't really a question, just a statement.
Yeah, I heard that as well with regards to going through the insurance companies as well, because obviously within America itself, you need health insurance, to go into the hospitals, one thing and another. So yeah, to go through insurance companies, that was their inroad, so to speak.
Yeah, and I think that they found that this model keeps people out of the hospitals and is actually cheaper for the insurance company, which is why it's been driven. But yeah, it's just some interesting software.
Yeah.
Thank you.
Thank you. Please keep your questions coming in. We've got a really good discussion going here, I think. We're waiting for Tricia, so we'll give her a few more minutes. I had a quick question around sort of communications with the public and other stakeholders, sort of in the system, to sort of raise awareness of the service and referrals into the service. I just wondered if you could say a little bit about what you've done really to let people know that this exists.
So from Jackie and my point of view, we haven't really put the word out, if that makes sense, because this has all been done via commissioners and we're on the ground. So at a strategic level, I'm unsure. Now, obviously, Jackie and I go to a lot of third sector organisations. We're well known within the trust. We're well known in mental health services and things like that. So we do promote ourselves, which obviously that comes along with a service. But with regards to, we don't have a Twitter handle. We're not allowed to have one because of council politics. We don't have any kind of social media, which is a big stumbling block, where you think we could put out good news stories and things like that, and spread the word of the HIU. But we do also have connections with the national leads, where Jackie will go on to the webinars and the seminars and stuff like that, and she will speak about the things that we do.
Robert and Jackie, Kat asked a question around the reduction in A&E with your patients, and I know you spoke to me about that as well, didn't you?
So on a monetary value, we are close to
Just over £1 million.
just over £1 million, and that's still with 9 months of data still to be recorded. And that was through COVID as well.
Okay. So what percentage would you say?
It's over
is it
40%.
40%.
It's
Yeah.
over. Yeah, because
Yeah.
one of the things is that we've not actually had the percentages. It's all done from a monetary point of view. Now,
Yeah.
if it wasn't over 40%, it wouldn't be recommissioned, because that was
No.
the target. I do know that in 2019 up to 2020, it was 63% reduction rate.
Yeah, that's
But
amazing.
But since COVID, we've not been able to get the percentage. Now, I don't know if that's because of the analysts, they're busy doing other things, but we've never had a percentage. We only get monetary value.
Right. And is that just percentage of those patients attending ED, or is it admissions as well?
So that's admissions, non-elective admissions, that's attending A&E, and that's also doesn't take into consideration the NWAS call-outs.
Right.
And it doesn't also take into consideration the 111 calls.
Right. So it'll be a lot higher, won't it?
Possibly,
and if
yeah.
we could connect the dots with the PCNs, the savings would be even more, wouldn't they?
Yeah.
You know.
The thing with that as well, Claire, is that you couldn't connect the 5 PCNs in Warrington with 2 members of staff. You'd have to you know, pump vast amounts of money into the service.
Yeah, yeah. And I think the hours roles, which, you know, the PCNs have access to, and looking at how we can work differently and reduce this GP activity and unplanned appointments, lend themselves so well, don't they, to this model of care and how we can support patients with this, you know, more socially led multidisciplinary team. And the data that, you know, that the small amount of work that we did, you know, just highlights that so much, that there's a real gap in the market. And the great work that you guys are doing is just a drop in the ocean, isn't it, compared to the activity that's out there?
Yeah, for sure.
Had a few compliments on the chat. So Deborah said, "Wow, that's brilliant." Deborah, I don't know if you want to come in and if you've got any questions or further comments. And you got a "wow, that's awesome" as well from Kath on those very impressive numbers. But we've got a few more minutes, so if anyone's got any other questions, please do post them in the chat.
I think just from an update point of view, if Tricia doesn't make it, I think the next steps kind of up in Cheshire and Merseyside was that the work that we've done with Clear, the commissioners have got that work now, and that's going to place board at ICB level, and they are looking to expand the services and how they can implement this model of care to complement Rob and Jackie's work that they're doing, but how they can kind of look at it from primary care as well as a secondary care perspective. And I know there's a great support for the work that's being done up there, and they are trying to drive it forward with everything else that they're trying to do as well. So we've had some really good engagement up there.
Any more questions, comments?
No.
So unfortunately, Tricia couldn't join us for this session, but I think we got a really good discussion going there, and it's just so fantastic to hear about this service you've got in Warrington, and the success you've had with it. I think it was a really fascinating session. So thank you, everybody. So thank you to our speakers and everybody who attended today.